This morning we have with us Professor Mark Edwards. Professor Edwards, we're grateful to have you here with us today. If you could take a minute and just tell us a little bit about yourself real quick.
Okay, well, thanks very much, Bridget. As you say, my name is Mark Edwards. I'm a neurologist and I work at a hospital called St George's Hospital, which is in London, and I'm a professor of neurology at the university and medical school there as well. And I have a background interest in movement disorders, which are neurological problems that affect people's movement, and probably the commonest of those is Parkinson's disease. But along the way, I became particularly interested in people who have functional movement disorders, and through that, people who have functional neurological disorder in general. And so I now run a clinical service which concentrates particularly on people who have functional neurological disorder, and I'm involved in trying to develop better diagnostic and treatment services for those people. And I'm also involved in research in functional neurological disorder, trying to understand a bit more about what goes wrong in the brain and also how best to treat it.
Wonderful, thank you. And I guess it's kind of fun to come back to this point. We did our first interview back almost, I think, 5 years ago. I can't even remember how long ago it was. Yeah. And so we're excited to have you back again to do some more. One of the questions is people questions start before they start to come in. One of the questions that we did have someone ask was, what specific questions should a patient ask of a new neurologist or movement specialist to determine if they are knowledgeable about FND?
Well, I think it's just really a good idea to have just a straightforward conversation with your neurologist. So you can just ask them the question, what do you know about functional neurological disorder? Have you seen people with functional neurological disorder? What treatments do you have available, or can you recommend for me? Functional neurological disorder is a very common cause of neurological symptoms. And so most neurologists, well, all neurologists will have seen people with functional neurological disorder, but it is one of those situations where some people have different attitudes to it. So some people might have more negative attitudes to it, although I think that's changing. And also some people just don't have very much experience of what to do or how to help somebody who has a functional neurological disorder. So they may be able to make a diagnosis, but they may not be able to perhaps explain it very well, or may not be able to know what the best kind of treatment is. So just ask your neurologist, have you seen this before? What experience do you have in treating it? And I think that any normal neurologist wouldn't mind being asked those sorts of questions. It's just the same questions you might ask if you have Parkinson's or MS or something like that.
Thank you. I think one issue that people have also is that there's so many different terms used as well. How would you explain maybe to patients that maybe have gotten a functional movement disorder diagnosis versus functional neurological disorder diagnosis? There's some confusion sometimes on the page, even conversion disorder. Can you maybe clarify some of those terminology issues with us for just a minute?
Sure. So you're right that in this area there are lots and lots of different terms that are used, and that causes quite a lot of problems. So there has been a move in recent times to switch a number of other terms that were used through to a term called functional neurological disorder. And so this word functional is meant to be describing the problem as a sort of malfunction rather than structural damage or degeneration. That's all it's really meaning. Because functional neurological disorder can present in lots of different ways, so people can have sensory problems, movement problems, seizure-like episodes, thinking, cognitive problems, doctors tend to subclassify the functional neurological disorder into different things. So if somebody mainly has a problem with movement, say, well, this is a functional movement disorder. If somebody mainly has a problem with thinking, might say this is a functional cognitive disorder. But that all comes under the umbrella, if you like, of a functional neurological disorder. There are quite a lot of other terms that are used, some of which are still current in some people's practice, like conversion disorder or psychogenic. And those are really, they have problems for me associated with them because, for example, the word psychogenic sounds like the only way of thinking about the problem is a psychological problem, and the only way of treating it is therefore with psychological therapy. Now, I think that psychological therapy can be a useful treatment for some people with functional neurological disorder, but I don't think it's useful for everybody. And I don't think the psychological level is the only way to think about symptoms. So that's why I don't use that term. Conversion disorder suggests that the problem is psychological stress converted into involuntary physical symptoms. And again, I think that can be relevant for some people, but not for everybody. And so that's why I think most people prefer this broader term for functional neurological disorder. And that's I think where the classification systems are going as well.
Thank you. That helps clarify things quite a bit. We have one question. We're going to kind of switch gears a little bit here. We have one question from one of our viewers, and she says she's a 61-year-old newly diagnosed FND patient awaiting her first collaborative care appointment at NHNN in June. Her problem is with a tachyc right leg, and her question is, can I deal with this myself if all care is based on diversion techniques, or do I need guided care? And if so, where's best, a NHNN or get referred to you, or is there someone else?
Sure. So, like I said before, functional neurological disorder presents very differently in different people, and also everybody has a different makeup themselves. So they might have other medical problems, and they might be physical health problems, they may be mental health problems. So you have to look at the whole person. So treatment looks very different for different people. I think that for a lot of people where the problem is primarily due to movement difficulties, so difficulty in controlling the movement of the body, then for those people, I think that they can often do a lot with distraction type techniques. So that means trying to kick in normal automatic movement rather than having to focus and control the body very carefully. But to be honest, that's something that's quite difficult. And I think it's something where people generally need some help. That's where potentially a physiotherapist could be a useful person to be involved. But it needs to be a physio who really understands those sorts of symptoms rather than somebody who has a general understanding of neurological problems. I think that the program that this lady's been referred to, which I know at the National Hospital for Neurology, that's a multidisciplinary program where physios, occupational therapists, and clinical psychologists are involved in trying to help people with functional neurological disorder. And I think that for a lot of people, that's a very good treatment. It's a bit difficult to comment in detail on the particular person because I don't know the situation, but certainly I think that multidisciplinary rehabilitation can be really helpful for a number of people. And I would at least go ahead and have the assessment for that program. But like I said, there are lots of different ways of treating somebody with a functional neurological disorder, and it really depends on the symptoms people have and other problems they might have going on too.
Great, thank you. Another question that we have is, I am suffering with extreme migraines, which are getting worse, but I'm getting pain in my head and neck, which isn't a headache, but it's real pain, which hurts to touch. Is this normal with FND? And it hurts every day.
Okay, so I think what that question shows is a really important point in this diagnosis of functional neurological disorder, which is that people can have more than one problem going on. And in fact, other neurological problems, for example, migraine, can often go together with functional neurological disorder. If you have migraine, that can cause a lot of symptoms, and people with chronic migraine, so migraine every day, all the time, are often very disabled by that. And that doesn't have to necessarily have anything to do with a functional neurological disorder. It can just be really bad migraine. And that's something where there are different types of treatment, but you need to really pursue treatment for migraine. There's then a group of people who have migraine, but then develop functional neurological disorder on top of that. So for example, I see some people with migraine who then develop paralysis of their body lasting a very, very long time, which I think is a functional neurological disorder rather than the migraine, but it's linked together. And sometimes in those people, I would treat their migraine and then the functional symptoms might get better. So I think that if headaches are the primary problem, then I would pursue treatment with that with a neurologist. If your neurologist is not helping, ask to get referred to a specialist headache clinic where, you know, neurologists who specifically specialize in migraine will be there, and that might be a way of helping things overall. Yeah.
I think that brings up a really good point, though, as far as just general comorbidities of other illnesses.
Yeah.
When should a patient go see a doctor if something else comes up, or when they're not sure if something is possibly FND or something else? I think that's always kind of lingering in a lot of people's minds. How do they tell? Or
sure. So it's a really good point, and it is tricky, and it's tricky because people with FND over time, or at least some people with FND, can develop a shift in their FND symptoms. So the FND might be presenting in one way, and then over time it might worsen a bit, or it might shift to a different symptom, which is still the FND, but it's just showing in a different way. But that's a situation that needs medical assessment. And so my feeling about this is one of the reasons why I'm very passionate about the idea that it's neurologists that should be at least primarily involved in the care of people with FND. That doesn't mean they do all the treatment necessarily, but at least there's a neurologist there as somebody that the patient could come back to if new symptoms develop. And I always write in the letters that I write back to referring doctors that if new symptoms emerge, then those need to be treated in just the same way as you would if somebody walked in off the street with that symptom and they didn't have anything else wrong with them before. Because people with FND can develop other problems as well, and they can have other medical problems going alongside their FND. So that's where you need some neurological expertise, and you need a person that you can trust to go and see and talk about symptoms. New symptoms may well be related to the FND, but they may not be. And so it just needs normal clinical assessment. At the end of the day, there is often some uncertainty going on in medical diagnosis of in whatever condition we're talking about. It's always a matter of probability. So you think, well, it's very likely to be this, but of course it could be that. And so that's a situation where sometimes you just need some time. So you need to make some reasonable assessments, come to a reasonable judgment about what's wrong, and then follow the person up. And if they're not, if things are not going the way you expect, then maybe you reinvestigate things. So it is important to, if new symptoms develop and they are persistent and important, to go and see your doctor and to get those assessed in a normal way.
Thank you for that. I think it is really important for everyone to remember that women are still at the same risk as having breast cancer as anyone else, or heart disease, or any of these other illnesses that are other common illnesses. And it doesn't, just because you have one, unfortunately, doesn't exclude you from getting something else. And so I think it is important that they be mindful of their health, but without being too worrisome, I guess, that they are going to catch anything else. It doesn't make them necessarily more susceptible to catching any of these other things. All right, thank you. We also have another question here, and I'm gonna see if Galaxy is what they're coming in as, but I'm going to go ahead and unmute you, and you can go ahead and ask your question.
Hello, Professor Edwards.
Hi.
Christine Nichols. We have met before in the
Hi.
past. Hello. I would like to ask Dr. Edwards, I have a cervical focal dystonia, but over the years it's spread all over my other parts of my body. I just wondered, in part of your research, have you found that there is a link between dystonia and FND? And therefore it might explain why my condition has become a little bit more complicated and still persists to this day to throw up anomalies.
Sure. Thanks very much for the question. I think that I would start by just thinking about the word dystonia. So dystonia is just a word which means abnormal posture. And so there are lots and lots of different ways in which people develop that. And there are some types of dystonia which are due to hardwired problems in the brain, where there's either damage or degeneration or some change in the wiring which produces dystonia. But I think that also dystonia, abnormal posture, can happen as a functional movement disorder as well. So that would be something where it's not a wiring problem, but it's more of a problem with the way that you're able to get access to or to control your body. So, and sometimes those things can overlap as well. So I've seen people who've got typical wiring damage dystonia, who then on top of that have developed functional dystonia and other functional symptoms. So I think that dystonia is a particularly complicated thing just from a neurological point of view to diagnose, because it's quite difficult to separate out wiring damage dystonia from functional dystonia, because we don't really have very good tests to do that. I think that with the sort of wiring damage type of dystonia, it generally follows pretty set rules of how it affects people and about progression. It generally doesn't progress. So I think that if things are acting in a way where it looks like there may be functional dystonia as well, or that is the main problem, then that would be something where you might think about additional treatment that you wouldn't generally use in typical wiring damage dystonia, where people generally just use botulinum toxin or medication. And you might think about using more rehabilitative treatments, although I accept that those are quite difficult to come by, but that's where specialist physiotherapy, for example, can be useful for some people.
Thank you. We have, sorry, Shreeve.
Sorry.
Sorry, you're muted. Thank you. Did you have anything further?
No, I would just ask. I did used to come to the National Hospital for 13 years and have had treatment now back in my own home hospital, but my physician has changed, and I just wondered if, even though I have come away from London for the treatment, I wondered if returning, maybe to even see if I could be referred to Dr. Edwards would be a good idea, or whether I just carry on and pursue here at home in Ipswich where I live, which obviously has a limited amount of resources.
So it's difficult to answer that directly, I suppose, but I'm always happy to receive referrals. Unfortunately, I have quite a long waiting list, but I would be happy to see anybody with a referral from your GP. Okay.
Thank you. We're going to kind of switch. We've got a couple questions here, and I'm going to group them together because they're both talking about patients that are 11 years old, 13 years old. One parent is asking that her son was seen at A&E in the Children's Hospital, and the doctor used the Hoover test to diagnose functional weakness as he couldn't work that day. It's also happened a couple other times over the past 3 months. Is this enough for it to make the diagnosis, or should this parent be pushing for more tests? And if so, we're going to put in the next question. A mother's asking, where or who do you suggest for treatment for young FND sufferers?
They're all good questions. So I think with the first one, the the diagnosis of a functional neurological disorder is, like any diagnosis, a combination of lots of things. So I would never say that on its own a positive Hoover's sign is sort of sufficient, if you like. So if you just walked into a room, did a Hoover's test and it was positive, and I wouldn't walk out saying, well, that's functional neurological disorder. I would think that probably that person had functional weakness, sure, but I would want to know whether there were any other things going on. And so that's where taking a proper history, doing a proper full examination is important, because, like we've been talking about, people with functional neurological disorder can have other medical problems which can trigger off things. And that could be both from a physical health and from a mental health point of view, or both. So it's important to do a comprehensive assessment. And that can sometimes include investigations as well, but not always. So I think that if there are persistent worries about the diagnosis, then it is reasonable to seek another opinion about it, and to make sure that things have been looked at in a proper way, in a comprehensive way. With the second question, I spend quite a lot of time shouting about the poor accessibility of services for adults with FND. Unfortunately, the situation is even worse for children, in my opinion, certainly in the UK. So there really aren't, unfortunately, good diagnostic or treatment services for children in the UK. I think that if somebody has a diagnosis of FND, then the child has a diagnosis of FND, then again, it's about what are the main problems that are going on. Because, for example, some people, their main problem is pain. And for them, there are specialist pain services, chronic pain services for adolescents and children, for example, at the Royal National Hospital for Rheumatic Disease in Bath. I think that getting assessed by a paediatric neurologist would be a good idea, because those people would generally have more knowledge of where treatment services are. And it is sometimes possible to put together a package of care from physios, OTs, and clinical psychologists from the local community. There is one program which is a rehabilitation program for young adults and adolescents at UCLH, which is a teenage rehabilitation unit, and that's run by a paediatrician called Joe Begent. And so that's one place that I do refer people who've got severe symptoms for inpatient rehabilitation.
Okay, great, thank you. We have another question here, and I believe it's from another physician, and they're asking, how do you approach a patient who presents with a past medical history of one neurological condition, such as multiple sclerosis, but then also appears to have some functional neurological symptoms on top of this?
So I would approach that in the way that it's really normal, it's really common, it's a really, really common thing to happen. So studies have suggested that at least 15% of people who have a neurological diagnosis such as MS or Parkinson's also have functional neurological symptoms as well. So it's a really common thing. And in fact, identifying it can be a really positive thing as well, because in some situations, the functional neurological disorder is the most treatable bit of the problem that is going on. So actually being able to positively diagnose that somebody has a functional neurological disorder as well as their MS, for example, can open up other opportunities for treatment and improving symptoms. So I think it has to be, like any diagnosis, it has to be explained in the right way. And that's that having functional symptoms, that's another real way to get neurological symptoms. It has no less value and is no less genuine than having MS or Parkinson's disease. It's just a bit different. It's just a bit different way that the brain's going wrong. And because it's a bit different, it often needs slightly different treatment, which is more focused on rehabilitation, sometimes multidisciplinary, sometimes unidisciplinary, and rather than giving people more medication, for example, or doing surgery.
Great, thank you. One of, as you explained some of the different symptoms that people have, and going back to talking about the different labels that patients are given, one of the questions our viewers have asked is, your description seems to suggest that there are possible subgroups to FND. Are some symptoms of FND treated with different approaches, and which symptoms, if they're identified as FND, correspond with what type of treatment?
Yeah. So that's a really good question, and I think that there are sort of three main categories of FND symptoms. So there are people who present primarily with movement problems, so say weakness or extra abnormal movement like tremors and abnormal postures. Then there are people who present with seizure episodes, so episodes where usually in between times they're okay, and then they have an attack of usually abnormal movement, but often with loss of awareness in some way, so they can't communicate or can't hear or maybe even have the experience of being unconscious. And then there are people who it primarily affects their thinking, so they have memory difficulties and concentration and attention difficulties. And so I think that, and against all that background, a lot of people with FND also have pain and they have fatigue. So those are quite common general symptoms, but for some people, the pain, for example, is the dominant problem, or the fatigue is the dominant problem. And so there are those sort of divisions, they do really need slightly different treatment. So for example, for people with movement problems, I generally feel that physical rehabilitation has quite a big role to play. And it makes sense because they're movement related problems, so you might be trying to retrain movement. But also often those people do need other treatment, which can include psychological help as well. For people with seizure-like episodes, the main treatment that has evidence is specialist psychological therapy. So that doesn't mean general psychological therapy, that means specialist psychological therapy from somebody who understands those non-epileptic attacks or seizure-like episodes. And there are techniques which people can learn that can try and help control the attacks. And then for functional cognitive problems, memory problems, there's very little evidence about what to do, to be honest. But I think generally it's likely to be a more cognitive / psychological type treatment, but again, something that needs to be really quite specific for those symptoms. And for pain and fatigue, there are important general things about pacing of activity, so avoiding boom and bust patterns of activity. And there are some specialist chronic pain management programs and fatigue management specialists who may be able to help with those symptoms. And sometimes you have to put all of that together in a sort of multidisciplinary treatment program. So it is quite complicated, but treatment triage, or sort of selecting people, the right treatment for the right person, is something which is very, very important. But I think the overall thing is that people with FND generally need to be treated by people who understand FND. It kind of makes sense. So if you see a physio and it doesn't make your symptoms any better, that may be because the symptoms are really difficult to treat, but it may be because the physio that you're seeing doesn't really understand the symptoms, is not doing the things that might well be helpful. So that's where specialist services can be important.
Thank you. I think you mentioned a really good point about that. Maybe it doesn't mean that physio wasn't helpful for them. It might be that the right physio wasn't used in the first place, which I think goes back to the very first question that we started with on anytime you're seeking treatment or care from someone, whether it was a neurologist, movement specialist, or physiotherapist, that you have that conversation right at the beginning to make them aware that there is specialist physiotherapy for FND and that they know how to provide that. And I think that can really help complications. We get a lot of patients once in a while that say, well, I tried that and it didn't work. Mm-hmm. And I'm always wondering if they tried it with someone that did know how to approach functional symptoms in a way that's helpful.
Yeah, I mean, I think that that's one of the reasons why I'm very keen on trying to get guidelines out there, because FND is a really common problem, and so it doesn't make sense that treatment for FND is only located in 1 or 2 centres around a particular country. It makes sense that it should be something which is offered much more widely than that. And so, for example, I've been involved in publishing consensus guidelines on what physiotherapy might look like for people with functional movement problems. There's just currently trying to get money to fund a multi-centre trial of physiotherapy to show how you might teach other people and show that it's a useful thing generally. There's a big trial going on in the UK looking at specialist cognitive behavioural therapy for non-epileptic attacks or functional seizures, which is using a specific protocol to try and, and if it works, then that's something that could be rolled out and becomes, more mainstream treatment. So it's only this way, by doing trials and by trying to push research, that we can get expertise out there generally. Because at the moment, it's very, very difficult for people to access treatment, which is very frustrating.
Well, and I think you bring up a really important point about the importance of research, because we can have these webinars and we can do all kinds of awareness and things like that, which are great. But when it comes down to the bare bones of it, we're not going to get answers, and patients aren't going to get the treatment that they need without the research to support the treatments that are being given. Maybe there's better treatments, but we can't find it if we're not researching them. I think in any country that we're in, the government is not going to give money unless they've got good, solid clinical trials to support that. And so we really appreciate the research that you're doing and the others that we've had on with the webinar. I know a lot of you work closely together trying to move things forward. And I can't help but think back to 5 years ago when we started this, that there really was only one program in the UK, and you were kind of a lone ranger kind of forging ahead in that, pioneering it. So it's so great to see that we are moving forward. It's slow going, but we are moving forward, and it is happening, and we really appreciate that. We're really run out of time. I do want to touch, though, if you have a few more minutes,
I do.
some specific questions for carers. I think carers a lot of times get left out of this equation, and they are such a vital part of the care that patients are getting. And I'm going to, again, try to group a few questions together that have come in that we've got a panelist, a viewer wondering what advice you would give to a carer on what support we can give. And then another one was asking, when his wife is completely paralyzed in bed, how does he know the difference of she's fine and she'll move soon versus I need to call an ambulance? And so I think there's just all these things and a lot of responsibility getting put on carers, and they don't feel like that they're getting the support and the information that they need to make these really important decisions on behalf of their patients. What advice can you give to carers?
Yeah, well, like with many chronic medical problems, I think carers have they have an enormous it is an enormous thing that they're doing in order to help people, their loved ones with FND. And I think that maybe starting with the second question first, if the person that you're caring for has episodes of symptoms, for example, maybe they have seizure episodes or they have attacks of paralysis, then in a sense, you need to get advice from your neurologist or doctors about what to do in that situation. It's not really fair to have that responsibility about what to do put just on you. So I think that's where I would usually say to people that if there's an established pattern of attacks, of paralysis or of seizures, and where the neurologist is clear that these are all functional attacks, so they're not some other problem, and if the attack is going the way that previous attacks have gone in terms of its duration and what's happening, then it's generally okay to not go to A&E, not to call an ambulance, because generally that's a pretty negative experience for a lot of people with functional symptoms. However, if an attack is out of the ordinary in some way, then it may be necessary to go to A&E, even just to be sure that everything's okay. But that's something where you need to really have a conversation with the neurologist to support you in that. I think carers have a very important role, I think, in trying to reflect back to people with FND certain. So carers can often be more aware, people with FND, of triggers to symptoms, of when maybe people are overdoing things and heading towards a sort of crash, and being able to sort of actually reflect to the person with FND, look, I don't think you look that well, maybe you just need to now stop what you're doing and take a break. So for a lot of people with FND, there is an issue where they might push, and they might, for example, one day feel a little bit better, and so they then do lots and lots and lots of stuff during that day, and then really exhaust themselves and have a crash then, and then a number of days they're in bed and can't do anything, and then the whole cycle repeats itself. So trying to get that to stabilize is really about pacing of activity. So that means pulling back a little bit before you're absolutely exhausted. And carers can have a role in helping people recognize that now is the time to stop, and giving people permission, if you like, to do that. Because often people with FND feel guilty or feel like they're being lazy if they actually stop before they're absolutely exhausted, which is nothing of the sort. It's just trying to manage the problem. And beyond that, I think it's really just the psychological support and comfort, and the advocacy as well, so that when you're going to say appointments with doctors, that the carer might be able to sort of write down questions for the person with FND. They might be able to help support them during that interview if they're getting tired or they're getting or having difficulty expressing what they want. So that sort of advocacy can be really helpful too.
Thank you. I think you made such a great point about giving permission to set those limits. I think that is often an issue where the patient is trying to push themselves so much because they don't want to be perceived as lazy or putting on or things like that. And I think that guilt and stuff can really just exacerbate a problem that's already there. Another thing I think that you mentioned that's also really important is how the care can help the patient recognize that they are overdoing it. And I think a really important thing I want to mention is that it's important that as a patient, you recognize when your carer is trying to help you, and you not be upset with them, but you recognize that they are trying to help. And even if that needs to be a conversation on how best to approach that, how best to receive that kind of information and how best to give it. Because I do think it is really important to remember that these boom and bust periods do affect the carers and the people that are trying to help you. And so it's important that you also respect, on a patient side, respect the effect that does have and try to work through that together in a way. I don't know if that makes sense. But
I think it is really important for carers and the people they care for to recognise that carers also need a break from time to time, and to actually schedule that, and for the person who's being cared for to give the carer permission as well to go, even if it's just for a couple of hours, to get your hair done or something, just because those little breaks ensure that it's possible for somebody to continue to care rather than develop their own health problems through just the intensity of what's happening. So
absolutely, and even a simple thank you, I think sometimes people can get into the monotonous routines and things like that, and sometimes you forget the simple thank you for doing that, you're welcome, and just remember some of those things too can really go a long ways. And so I think that's a great place to end it. One last question: what is your hope for the future of FND? How would you like to see it?
So my overall hope is that FND just becomes a normal medical problem. So we have expectations, reasonable expectations about medical problems, say for example MS, that if you have MS, then there's people who are interested in looking after you. There are services there to help you. There are, there's support from a social point of view, from a societal point of view, and that's just a normal way in which we approach illness. So my hope for FND is it just turns into that. At the moment, too often it's just seen as this sort of weird, different thing which needs to somehow be managed in some weird, different way. But it's nothing of the sort. It's just another way in which the brain goes wrong, and we just need to treat it that way. So my hope is that one day that will be all it is, and people say, "Oh, you have FND? Oh, yeah, I've heard of that. There's that service you can go and get treatment for, etc." So yeah, that would be what I would hope.
Well, thank you, Professor Edwards. We absolutely appreciate the time you've given us, and we've got lots of questions still, but we can't hit them all every time. I encourage everyone.
Happy to come back.
Yeah. So we hope to have you again. Our next webinar will be June 13th with Dr. John Stone, and hopefully we'll catch Dr. Edwards at another time as well. And we want to just thank everyone for joining us. Thank you.
Okay, bye-bye.
Bye.